This is going to be topic 32, psychiatric disorders.
Key concepts. Upon completion of this chapter, you'll understand that mental illness is a common disorder that paramedics will frequently encounter, how assessment focuses on life threats and on any of their reversible causes, that acute medical conditions must be ruled out through evaluation at a medical facility before patient placement in a psychiatric facility. Chief concern. Psychogenic theorists or psychologists focus on unresolved conflicts between inner desires and opposing external demands. Somatogenic theorists or psychiatrists accept psychotic behavior as a central nervous system malfunction and figure that there's an imbalance among the neurotransmitters. Mental illness, departure from the normal patterns of behavior, heredity and age come into factors here. Heredity may play a role in some mental illnesses. The two extremes of age, adolescence and census, are times when mental illness, particularly suicide, is most often manifested. Modern psychiatric revolution. Advent of psychotropic medications. Psychiatric medicine changed from institutionalization to psychiatric medications. Consequences of this moving away from these institutions were increased homelessness. Differential diagnosis and schizophrenia. Over 350 individual mental disorders. Diagnostics and Statistics Manual 4th edition, or the DSM-4, is a guidebook for the diagnosis of mental illness. Schizophrenia, primarily a problem of thinking. Positive and negative symptoms. On the positive side, they are positive for hallucinations, delusions, disorganized speech, disturbances of speech, and emotional disturbances. Pressured speech, rapid, often loud, always empathetic, and almost nonstop. Verbigeration is an obsessive repetition of meaningless words and phrases. Stilted speech, use of an extremely formal terminology in everyday conversation. Negative annotations, elogia, affective flattening, and evolution. Elogia, poverty of speech, evident when the patient is unable to sustain a conversation. Monosyllabic, one-word answers to even open-ended questions. Affect, outward expressions of feeling and emotion, seen in body language and speech. Affective flattening, lack of emotional expressiveness. Avolition, lack of desire to complete a task or assignment that the patient has the skills to do. Schizophrenia subtypes. Simple schizophrenia starts insidiously with social dysfunctional behaviors that progressively lead to an inability to perform daily living activities. Hebephrenic schizophrenia, regressive behaviors, inappropriate affect, and hypochondriac complaints. Excited variety of catatonic schizophrenia, patient is hyperactive to the point of violence. Classic presentation of catatonic schizophrenia is the exact opposite of what you would think. You would think they would be comatose, but they're actually quite hyperactive. Paranoid schizophrenia, thought disorder, which gives rise to a symptom pattern of delusions and hallucinations. Delusions of grandeur. Patient feels that they are especially important and have been selected for a special mission or quest. Table 17.1 is the next thing we're going to look at, which is a partial list of psychiatric disorders. And these are some of them. Schizophrenia, simple, schizophrenic, catatonic, and paranoid. Mood affective disorders, unipolar, bipolar disease or manic depressive, postpartum depression, anxiety, phobias, panic disorders, post-traumatic stress disorder, somatoform disorders, factitious disorders, dissociative disorders. These all come from that DSM-4. Eating disorders, anorexia and bulimia, impulse control disorders, and personality disorders. We're going to talk about a few of these in the next slides. Affective disorders. Psychological disorder that affects the mood. Clinical depression, protracted and or debilitating depression, not a response to identifiable external stimulus. Symptoms are persistent and unrelenting sadness, inability to experience pleasure or joy, and loss of normalcy. Somatizing. Patient will take internal psychological distress and externalize it into physical distress. Bipolar disease, manic depressive illness, two states. There's either mania or depression. Symptoms in the depressive stage. Same symptom patterns as a patient with clinical depression, sleep disturbances, anorexia, adhedonism, which is the inability to experience pleasure or joy. The manic phase, patient is seen as energetic and outgoing. Anxiety disorders, several of those as well. Major classifications are general anxiety disorder, which is all pervasive tension that is a result of exaggerated worry and constant anxiety about the facets of daily living. So daily life has just got them at the edge. Obsessive compulsive disorder, reoccurring thoughts or obsessions and repetitive behaviors, such as compulsions that manifest themselves as rituals. Their compulsions are almost ritualistic. Phobia, unreasonable fear of anything. Social phobia is an overwhelming anxiety during social encounters. Panic attack, sudden, brief, overwhelming feeling of fear that is a part of the panic disorder. Post-traumatic stress disorder, or PTSD, occurs following a life-threatening event, such as personal combat or violent sexual assault. Flashbacks. The patient experiences persistent and repetitive memories of the event. Patient may seem aloof or emotionally cold because of difficulties they have expressing emotions. Delirium and the elderly. State of acute confusion, a metabolic encephalopathy, an altered mental state, or an organic brain syndrome. Risk factors for this, drugs or any type of electrolyte imbalances, or the lack of drugs if treating a mental illness, infection, reduced sensory input, intracranial source, uremia, or myocardial disturbances. The DSM-IV definition, patient's disturbances of consciousness, a reduced ability to focus or sustain attention, and or change in cognition, or the development of a perpetual disturbance that develops acutely and has a fluctuating course. In delirium versus dementia, we're going to look at two tables. Table 17.2, which are the potential reversible causes of delirium, and Table 17.3, the differences between delirium and dementia. The word spelled out delirium, drugs could be in effect, electrolyte disturbances, lack of drugs, an infection, reduced sensory input, intracranial source, uremia. This would be toxicity from kidney failure of some sort, or a myocardial cause. And then this is Table 17.3, differences between delirium and dementia. The onset of delirium, sudden, and dementia, it's gradual. Attention, globally disordered. In dementia, their attention is normal. Cognition is disordered as well in delirium. And impaired in dementia. Hallucinations are visual. In dementia, they're absent. Psychomotor, they're agitated. In dementia, it's normal. Speech, incoherent. And speech in dementia, preservation, difficulty finding words. So, just like I was having right there, I may have a little dementia start. History. Considerations on the history. Not all abnormal behavior is bizarre. Gathering history may be challenging. Maintain calm and deliberate demeanor with a patient. Exchange introductions. Ask about the chief concern. Use open-ended questions. Maintain interest. Practice your skills, your active listening skills, stopping for reflection, and permitting the patient time to mentally process the question. The ABCs of mental status examination is a systematic assessment of psychiatric status that creates a symptom complex. We're going to look at two tables. This is the first one, Table 17.4. This is a simplified mental status examination. What is their overall appearance? Are they affective? What is their attitude? What is their general behaviors? Their cognition level, delusions and hallucinations to be assessed for. This is Table 17.5, signs of formal thought disorders, clang association, which would be rhyming words, cognitive slippage, broad categories that are linked together, echoalia, echoing other people's speech, flight of ideas, switching topics in mid-sentence, neologisms, new word meaningful only to the patient, preservation, persistent repetition, again and again and again, thought blocking, interruption in the train of thought, or word salad, incoherent string of words. First, rank symptoms. Distinguishing schizophrenia from other mental illnesses, mnemonic ABCs. Are they having auditory hallucinations? Are they broadcasting? Broadcasting is the patient's belief that he can insert his thoughts into the minds of others and can read others' thoughts, or telepathy. And then C, controlled thought. Patient believes that others can insert thoughts into his mind. Thought blocking, patient running dialogue suddenly stops. Loose association, string of topics in a conversation that do not appear related to one another. Medications are broadly divided into two categories. There's antidepressants, which pretty much interfere with the neurotransmitters of the brain, and antipsychotics. They do not cure the psychosis, but they make the symptoms tolerable. On examination, organic causes of psychotic behavior are secondary psychosis. We should always consider that the patient may have this period of psychosis from an outside source. Toxicology would be one of those. They have a tumor growing in their head, things like that. So always keep an open mind at first. Systematic head-to-toe evaluation, formulate a general impression on the patient's appearance. Rhythm analysis of the patient's EKG, and an abbreviated neurological exam. In the assessment, acute psychotic disorder, symptom complex of hallucination and delusions, or history of long-lasting mental illness, brief reactive psychosis. Be sure and get as much history as you possibly can on these patients. In treatment considerations, word questions very carefully. Ill-chosen words can be devastating. Allow patient to express themselves. Avoid force in the conversation. Neuroleptic or antipsychotic administration of the drugs. Short-term relief for psychomotor agitation, confusion, and hallucinations. Upon evaluation, acute dystonic reactions should always be a thought in our minds whenever we use an antipsychotic. It's an idiosyncratic or idiosyncrasy reaction associated with the use of antipsychotic medications. It causes lead pipe rigidity, increased muscle tone in the extremities that resist movement, or cogwheel rigidity, which is a spasmodic movement of the extremities when taking a blood pressure, for an example. Neuroleptic malignant syndrome, potentially life-threatening adverse reaction to psychotropic medications. Symptoms are muscular rigidity, fever, and fluctuating vital signs. Serotonin syndrome occurs when a patient takes an antidepressant medication such as an SSRI, an MAOI, or a TCA, and has excessive levels of serotonin. Risk factors, any kind of continuous use or concomitant use of illicit drugs such as methamphetamine or MDMA, which is like ecstasy. Disposition. Considerations, transport to a medical facility for evaluation before transfer to the mental facility. Carefully document the source of the call. Document the clinical findings, the appearance, and the behavior and thinking, and their speech. In conclusion, psychiatric disorders are relatively common. Paramedics may be called for an acute decompensation or unrelated concern. Understanding of the manifestations and the appropriate treatment will allow better treatment of the whole patient.
If you have any questions concerning this topic, feel free to contact me. My name is Roy Smith, SmithArtSamaritanEMSOK.com or 405-492-8243. Thank you.